All right, today we are going way beyond just memorizing drug names. We're going to put on our detective hats. Because let's be real, in pharmacology, knowing the right questions to ask is what separates a routine shift from a disaster. So let's open up these case files. And this really says it all, doesn't it? The stakes just could not be higher. Every single medication you give is a critical decision. And as you're about to see, a nurse's sharp eye is so often that last crucial line of defense against a really tragic outcome. So here's what we're going to do. We're going to walk through 4 different case files. Each one is its own little puzzle, right? A set of symptoms, a med list, and a hidden danger lurking somewhere in the details. Your job? Try to spot the clues right along with me. Okay, case number 1. This whole thing starts with something you've seen a million times, a patient with a cough. But as you'll see, what's really going on is way, way more critical. So let's look at the chart. We've got a 36-year-old with a history of depression. Now, check out these vitals and symptoms. A heart rate of 140, a temp of 102.6, muscle rigidity, sweating. These are huge red flags. But the 2 most important clues for investigation are right at the bottom. They're on an SSRI, and they just started taking a new over-the-counter cough medicine. So here it is, the million-dollar question for our nurse detective. What is causing this absolute mess of symptoms? Is it the antidepressant, the cough syrup, or something else entirely? And the culprit? It's the cough medicine. You know, specifically, an ingredient you've probably seen 100 times, dextromethorphan. So how on earth does a simple cough suppressant cause a crisis like this? Well, this is a textbook case of serotonin syndrome. See, the patient's SSRI is already doing its job, right? It's boosting serotonin. What they had no way of knowing is that dextromethorphan also boosts serotonin. So when you take them together, boom, you get this toxic overload, a perfect storm that sends the whole system into a tailspin. It's incredibly dangerous. Now for our second case. Here, the big clue isn't some dramatic drug interaction. Nope, it's one of the most common things patients complain about, muscle soreness. It's so easy to just brush it off, but for this patient, it's a massive red flag. Okay, our patient is on simvastatin, one of the most common cholesterol drugs out there, and they're reporting new, pretty significant muscle pain and weakness. Now, this is a tricky one because is it just a normal side effect, or is it a sign of something much, much worse? A good detective knows you have to dig deeper. So the provider orders a bunch of labs. Which specific lab value are we looking for? The one that's going to tell us, uh-oh, this is way more serious than just a little soreness. The danger we're worried about here is called rhabdomyolysis. It's a rare but super serious side effect of statins, where the drug actually causes muscle tissue to break down. I mean, literally fall apart. This breakdown floods the bloodstream with proteins that are just brutal on the kidneys and can lead to total kidney failure. The smoking gun is right there in the labs. We're looking for something called creatine kinase, or CK. It's an enzyme that pours into the blood when muscle gets damaged. And in rhabdo, that CK level won't just be a little bit high, we're talking more than 10 times the normal limit. That's not a warning sign, that's a full-blown medical emergency. Let's move on to case number 3. This time, we're dealing with anticoagulants. These are high-alert meds where you're constantly walking this tightrope between preventing a deadly clot and causing a catastrophic bleed. Let's just quickly compare the 2 big ones, heparin and warfarin. As you can see, they work differently and they need totally different lab monitoring. For heparin, you're glued to that PTT and watching for any sudden drop in platelets. But for our case today, we're all in on warfarin, where everything, and I mean everything, boils down to one number, the INR. So a good therapeutic INR for someone on warfarin is usually somewhere between 2 and 3. Our patient's lab just came back, and it's a 6. That means their blood is way too thin. The risk of a major, spontaneous bleed is now through the roof. You see that number pop up on the screen, and you have the next dose of warfarin sitting right there in your hand, due right now. So what is the single most important, correct action to take in this exact moment? The answer is simple, and it is absolutely non-negotiable. You hold the dose, and you notify the provider immediately. You don't guess, you don't wait to see what happens, and you never, ever adjust the dose yourself. Your job as the detective was to find the clue, that critical INR of 6. Now, your job as the nurse is to report it. That's how you save a life. Okay, on to our final case, which really builds on this whole theme. Sometimes the most powerful thing a nurse can do is not give a medication. And this is especially true when you're talking about cardiac drugs. For a lot of cardiac meds, the decision to give it or not often comes down to the vitals. A heart rate under 60 is a classic reason to hold a dose, for sure. But sometimes the most important clue isn't on the monitor at all. It's hidden in the patient's lab work, specifically their electrolytes. And that brings us to one of the most classic puzzles in all of pharmacology, the dangerous dance between digoxin and potassium. So think of it like this, okay? Digoxin and potassium are both trying to park in the same spots on the heart cells. They're competing. Now, what happens if the potassium level is low, a condition called hypokalemia, which is often caused by diuretics? Well, suddenly there are all these extra empty parking spots, right? And digoxin just swoops in and takes over. This allows way too much digoxin to bind to the heart, which can lead to toxicity even at a totally normal dose. So the big takeaway is this. If your patient is on digoxin and a diuretic like furosemide, you have to be obsessed with their potassium level. A low potassium is a direct setup for digoxin toxicity. It's a connection you just can't afford to miss. So, we've cracked 4 cases. What did we learn? What are the golden rules for being a top-notch nurse detective? Here they are, the golden rules for the nurse detective. Rule 1, be suspicious. Always question a new symptom after a new medication is started. Rule 2, know your evidence. You have to master the critical lab values for these high-alert drugs. Rule 3, understand the motive. Don't just memorize that 2 drugs interact, understand why they do. And finally, the most important rule of all, know when to call for backup. Holding a dose and picking up the phone is one of the most powerful, life-saving things you can do. Look, these cases aren't just hypotheticals from a textbook. This stuff happens every single day. The clues are always there, just waiting for a sharp detective to find them and put the pieces together. The only question is, when the time comes, are you ready to solve the case and make that call?